If you have been on opioid pain medication for a long time, you may have lived through something that makes no sense on paper. The dose went up, and the pain got worse, not the same, worse. Most people assume one of two things when that happens. Either the disease is progressing or they are becoming a complainer. I want to offer you a third explanation, one that has a name in the medical literature and a mechanism behind it. It is called opioid-induced hyperalgesia. Hyperalgesia means increased sensitivity to pain. Opioid-induced hyperalgesia means the medication you are taking to reduce pain has begun, paradoxically, to amplify it. Your nervous system has become a louder amplifier, and the thing turning up the gain is the drug. This is not the same as tolerance, and the difference matters enormously for what you do next. With tolerance, the drug still works. You simply need more of it to get the same relief. With hyperalgesia, the pain system itself has been recalibrated. More drug does not fix it. More drug feeds it. Here's the practical way to tell them apart. With tolerance, raising the dose helps, at least for a while. With hyperalgesia, raising the dose gives you a brief improvement and then a worse baseline. The pain often spreads beyond the original injury. It changes character, becoming more diffuse, more burning, harder to point to. And ordinary sensations that should not hurt begin to hurt. Bed sheets, a light touch, a shower. If that describes you, you are not imagining it, and you are not failing at being a patient. Let me explain the biology because it is genuinely elegant, and because once you understand it, the treatment plan stops sounding arbitrary. Opioids work by binding to the mu-opioid receptor. That receptor is not a simple on-off switch. It is a dynamic protein with its own regulatory machinery, and it is designed to be stimulated intermittently, not continuously. When an opioid binds, a cascade begins. The receptor's tail, the C-terminal tail domain, gets phosphorylated. That phosphorylation recruits proteins called beta-arrestins, and the arrestins pull the receptor down into the cell and uncouple it from its signaling partner. The receptor goes quiet. This is called desensitization, and it is not a malfunction, it is a thermostat. In 2015, Birdsong and colleagues at Oregon Health and Science University published cellular work in molecular pharmacology showing precisely how phosphorylation of that tail domain modulates both agonist binding and desensitization. I want to be careful and honest here. That is laboratory work at the level of the receptor. It explains a mechanism. It does not by itself prove what happens in your body over 5 years of prescribed therapy, but it tells us what the receptor is built to do. And what it is built to do is cycle, bind, signal, desensitize, recover, resensitize. That recovery phase, the rest period, is where the system reestablishes its baseline. Now consider what happens when an agonist is present continuously, around the clock, month after month. The receptor never gets its rest period. The regulatory loop that was designed as a thermostat becomes a permanent state of downregulation. The system compensates by turning up excitatory signaling elsewhere. And you end up with a nervous system that is, in net terms, more pain sensitive than when you started. This is how we put it to pharmacists and referring physicians in writing on our website. The mu-opioid receptor is a G-protein coupled receptor regulated by phosphorylation of the C-terminal tail domain, which facilitates recruitment of beta-arrestin proteins and subsequent receptor internalization. When an agonist is constantly present, this regulatory feedback loop drives receptor desensitization and uncoupling, contributing to opioid-induced hyperalgesia, a paradoxical increase in pain sensitivity despite escalating dose. Fair question. Mechanism is not evidence. The foundational human review is Angst and Clark's qualitative systematic review in anesthesiology in 2006, which pulled together the evidence that opioid exposure can increase pain sensitivity in people, not just in cell cultures. More recently, Higgins, Smith, and Matthews published a systematic review and meta-analysis in the British Journal of Anesthesia in 2019, looking specifically at clinical populations after chronic opioid exposure, and found evidence consistent with hyperalgesia. Guichard and colleagues reviewed the published case literature in chronic pain patients in the Clinical Journal of Pain in 2021. Mercadante, Arcuri, and Santoni reviewed the tolerance and hyperalgesia relationship in CNS drugs in 2019. So there is a real literature, and I am going to tell you where it is weaker, because you deserve that. In 2012, Chu and colleagues ran a double-blinded, randomized, placebo-controlled trial of sustained-release morphine in chronic low back pain and found clear analgesic tolerance, but they did not find demonstrable hyperalgesia. That is a well-conducted study, and it means the honest position is not that opioids always cause hyperalgesia. The honest position is this: hyperalgesia is a real, mechanistically grounded phenomenon that occurs in some patients on long-term therapy. It is under-recognized, and it should be actively looked for rather than assumed either way. That is a clinical judgment made patient by patient, which is exactly how it should be made. Here's why this gets missed so often. There are at least 4 different reasons a long-term opioid patient reports worsening pain, and from the outside, they look the same. The patient says the same sentence: "It is not working anymore, and I need more." The first is tolerance. The drug is still effective, the receptor system has adapted, and a dose increase genuinely helps. The second is disease progression. Something structural actually got worse. A disc extruded, a joint collapsed, a nerve became entrapped. The pain report is accurate, and the medication was never the issue. The third is between dose withdrawal. With short-acting agents, as each dose wears off, patients enter a mild withdrawal state, and withdrawal itself is painful and heightens pain sensitivity. That can masquerade beautifully as hyperalgesia, and it is treated completely differently, usually by adjusting interval and timing, not total dose. The fourth is genuine opioid-induced hyperalgesia. 4 different problems. 1 presenting complaint. If you do not distinguish between them, you will treat all 4 by escalating, and you will be wrong 3 times out of 4. So how do we sort it out? Partly by pattern. Hyperalgesia tends to spread beyond the original anatomical territory, beyond the dermatome, beyond the joint that was injured. It tends to bring allodynia, where a light touch or a bedsheet hurts. It tends not to respond durably to increases, partly by ruling things out. We re-image where indicated, and we use electrodiagnostic testing, EMG, and nerve conduction studies to see whether there is a structural or neurological explanation that has been missed. We do not diagnose hyperalgesia by exclusion of effort, and partly by a careful monitored trial of reduction. If a slow supported dose reduction is followed by pain that improves rather than worsens, that is highly informative. It is also, frankly, the only way to know in many cases. That last one requires trust, because I am asking a frightened patient to go down before they go up, which is why we do it slowly, with support around it, and never as an ultimatum. If we suspect hyperalgesia, the counterintuitive move is the right one. We reduce carefully rather than escalate. I want to be precise about what tapering means here, because the word frightens people, and often for good reason. Many patients have had it done to them badly. Again, from our published protocol. We treat medication as a bridge, not a destination. Tapering is not the withdrawal of support. It is the measurement of the body's improved self-regulation as the pharmacological noise is removed. Tapers are calculated from clinical stability, progress in physical therapy and movement, and metabolic markers. Never arbitrary schedules. Never arbitrary schedules. That is the load-bearing phrase. Abrupt or forced reduction is genuinely dangerous. There is good evidence associating dose tapering with increased risk of overdose and mental health crisis, which is precisely why it has to be done gradually, with monitoring, and with something real replacing the medication. That something real is the rest of the plan. Interventional treatment aimed at the actual pain generator. Physical therapy, a minimum of 12 sessions a year in our practice. Psychological support, sleep and circadian repair. Metabolic and nutritional work, because chronic pain is frequently an extension of systemic metabolic inflammation rather than a purely neurological event. And we hold ourselves to a number. If a patient asks for a repeat procedure, we require documentation of at least 50% functional improvement to justify it. If we cannot show the treatment is working, we stop it. That applies to our injections and it applies to our prescriptions. Here's what I most want you to take away. If your dose has been climbing and your pain has been climbing with it, that pattern is information. It is not proof that you are drug seeking, and it is not proof that you are getting worse structurally. It may be the predictable behavior of a receptor system that has not been allowed to rest. And please hear this clearly. Do not change, stop, or reduce any prescribed medication on your own. Opioid withdrawal is medically hazardous, and abrupt discontinuation carries real risk. This is a conversation to have with your physician, with a plan, and with monitoring. If you want that conversation, we are at the Padda Institute, 4477 Woodson Road, Suite 100 in St. Louis. Call 314-481-5000 or text 314-886-5902. Your pain signal was valid. The question is what has been amplifying it.